Hello, dear friends. Probably the topic which I will be discussing today is offbeat, a topic we have attended so many conferences, so many chapters or CMEs. We never tend to discuss therapeutic inertia, which is a is a important thing. In fact, uh, so my topic for today is leveraging personalized diabetes care plan to overcome therapeutic inertia. So, what is therapeutic inertia? Now, in technical terms, when you use a therapeutic means drugs or treatment part. Inertia means, by dictionary meaning of inertia, is a tendency to do nothing or to remain unchanged. We call it, in northern, we call it sote rehna, so jana, nothing to do. So this is what is called as a therapeutic inertia. Diabetes is a disease which is a chronic progressive disorder, in which the treatment of which requires a constant vigil, and you can never sleep while treating a patient of diabetes over a prolonged period of time. Diabetes is a progressive disorder. Diabetes increases the risk of micro and macrovascular complications, and 20 to 40% of the diabetic patients have CKD in various stages, and 50% of the diabetic patient, they have neuropathy. It so happens that diabetes is the leading cause of death. It's a seventh cause of death, leading cause of death in USA. So why we are having so much of a therapeutic inertia when the disease is, such a kind of disease which gives so many complications? It burdens the public health system. So therapeutic inertia in this type of disease is not, has to be abundant. But some or the other, every chronic disease have some inertia, more so with the diabetes. So we have, over the past year, or I will put it around a century, when there was no hope for diabetics, and now we have, a patient who is now having wants to increase his life without any complications. So over the past 20 years, we have many options for managing type 2 diabetes, right? We have almost 12 different class of drugs, right, which we can give and treat the patient. But at the same time, although we have so many drugs available, but still diabetes control is not proper. I will be showing you next slide. But just to see in this slide, what I've shown is that insulin was discovered in 1920s, and then sulfonylurea. Of course, metformin has come before also, but in the USA, it came into the market after the 1990s. And standards of care made their first debut in 1989. And thereafter, you have plethora of drugs, starting with alpha glucosidase inhibitors, rapid acting insulins, basal insulins, maglitinides, and GLP-1 receptor agonist, then pramlintide and DP4 inhibitors, and bromocriptine, and last on the block is SGLT2 inhibitors, which are there currently. They are the number one or widely prescribed drugs in every country. So this is what I will say, that okay, we have so many drugs, right? This is the chart which is showing from 2007 to 2014. In fact, what has happened, the individualized target have been going down rather than going up. With the advent of so many treatment strategies, it's going down. The control was 69.8 in 2007. It has gone down to 63.8 in 2014. That's the target of the HbA1c, individualized target. And more than 9% of HbA1c has factually gone from 12.6 to 15.5. So although we have so many drugs, but the control is not going down. It's rather going little up. So this is the chart which is showing that DP4 GLP-1 was approved in 2006. Around that, you have increased adoption of electronic health records and iPhone and apps introduced in this era. And then we have Affordable Care Act becomes law here, meaningful use of implementation and ASO formulations, and then SGLT2 approval in 2012-13. So all these things are there, but still What we lack is that HbA1c control is not individualized control, as well as more than 9 HbA1c has gone up. So why it is up? It's because of therapeutic inertia. Briefly, I will go into three terms which we generally use. That's a clinical inertia, then clinician inertia, then therapeutic inertia. This is a therapeutic inertia. Is a part of clinical inertia. What is clinical inertia? Clinical inertia is a broader term referring to underuse of intervention known to prevent negative outcome. These are intervention maybe in screening, maybe in the risk assessment, maybe in the preventive measures, maybe in the therapeutic measures also. So clinical inertia takes all things into account. The clinician inertia is a specific to the clinician. A clinician is not able to implement the clinical aspect of the management. And therapeutic inertia is it's a inertia in which you don't change the drugs, don't change the therapies, which is required at this point of time. Although we know that it is required, although we know that it's good for the patient, although we know that it is recommended by the various agencies or various ADA like ESD or associations, various associations who have recommended it, but we are not implementing. So that's the, in fact, therapeutic inertia. And therapeutic inertia is multifactorial. So various causes are there, but I will put it in three broad headings. One is a provider-related factors, another is patient-related factors, then third is healthcare system-related factors. First is provider-related factors. There are many factors to it. In the Indian setup, we have have tried to add those factors also, like overburdened physicians, because you have to see so many patients, so you can't apply your brain or apply your best efforts in the treatment of the patient. And number second is, apart from the another thing is taking the disease lightly, that it's a diabetes, okay, take one tablet, okay, get the sugar done whenever you want. We tell many physicians may tell the patient, but it's not so. Diabetes is a serious disease. It's a it gives so many complications, right from the CVD, CAD, and all those things. So in fact, diabetes is a book of medicine itself. All the complication in the medicine book, textbook, are there in a diabetes. And use of soft excuses to avoid intensification. There's a lack of material, time, training to appropriately escalate care to meet recommended targets. There's lack of knowledge and resources to escalate or de-escalate the therapy. And then there are, of course, communication issues also. And then lastly, I will put it, ever-evolving guidelines. You have guidelines which were saying first you use metformin, then you use sulfonylurea, then again there is a changing goal of therapy, like ACE says 6.5, ADA says 7%, and there is a goal of therapy is not so well defined, and there is some message may say that this is the goal, other may say this is the goal, which one to follow. And specificity of drugs and need for patient-centered management. So we have provider-related factors in this specificity of drugs. Presently, the whichever, if you have read ADA 2000 standard of care, then there is a specificity of drugs nowadays, that you have these drugs which are effective in ASCVD, these are effective in heart failure, these are effective in CKD, and when cost is an issue, these are the drugs to be taken. When weight gain is an issue, then these are the drugs. Now we have going into specificity of the drugs. That's a good change. In fact, that gives you a guideline. Otherwise, after metformin, you have 6 agents. You can use any one of them depending upon your own judgment in the best interest of the patient. Then are patient-related factors, like there's a difficulty in making changes to lifestyle and medication that can put a drag on the HbA1c, achieving the HbA1c, medication side effects and cost, and psychological insulin resistance. That's a reason why patients are like potential permanence of therapy, complex and restrictive plans, and he is fear of hypoglycemia. There's a failure on the part of the patient. Patient thinks that probably he can do better by doing more exercise, taking drugs, taking diet properly. So whatever, although we know that is a progressive disease, beta cell function is going down, but patient may think the otherwise, that probably he's failing on these accounts, so that that's why his blood sugar is going up. Then weight gain, hypoglycemia, then depression, which is there in almost 9 to 14% of patients of diabetes, then multiple comorbidities and consequent load of medication. This is another thing. Then non-medical sources giving advice and patients following those also, like he may be taking Ayurvedic, he may be taking Unani medicine, he may be following the homeopathic medication simultaneously also. So that also interfere with the patient's achievement of the targets. Then system-related factors like diabetes education, lack of universal clear guidelines, and cost of therapy is another issue. There's a role of state, insurer, or NGOs. In India, most of the patients have to take the medicine from their own pocket, and OPD treatment is, almost all the patient they take from their own pocket. So what is the prevalence of therapeutic inertia? We have defined that there is a therapeutic inertia, and we have gone through three major issues, that is a providers, patient, and system issues, which are responsible for therapeutic inertia. What is the prevalence of therapeutic inertia? UK clinical practice data link base says that it took more than 3 years to intensify from 1 OHA drug to 2 in patients with HbA1c of more than 7. Another data from the same, practice link data from 15,000 patients showed median time to initiate insulin therapy was 7.7 years, despite HbA1c of more than 8% and patient being on more than 2 OHAs. And study from urban African Americans showed that diabetes treatment was only intensified at 50% of clinic visits, despite not being at goal. So although what is required is that therapy was to be changed, but only it was intensified at 50% of the visits. Diabetes in Canada evaluation has shown that 50% patient at primary care had HbA1c above target, and 56% of primary care physicians intended to intensify treatment or consider referral. That means 44% still are not convinced to intensify the treatment. Dance study, which was from Japan, and Japan study, the mean HbA1c of 7.5% and multiple reasons for not starting insulin from the dance study. Failure to de-escalate therapy is also a component of inertia. Not achieving target for blood pressure and dyslipidemia is also part of therapeutic inertia. So therapeutic inertia is not the only thing that you have to bring down the HbA1c or bring down the blood sugars. It's also for blood pressure, also for lipids also, and de-escalation of therapy also. So this is a treatment intensification in patient with type 2 diabetes who failed metformin therapy. You can see here, this is the median time here, proportion of patient on metformin monotherapy. For all patient data is here by index HbA1c. When the patient's HbA1c is more than 9%, the second agent is added earlier. But if the patient is having 7 to 8, although we require it is 7, the referral or second drug was added quite late. You can see here 3, mean here, almost close to 2 years. And when the HbA1c is more than 9, probably it's a half year. So median, so this is 19 months. This is a F is 8 to 9, then 8.7 months. So this is what is happening. And the metformin daily dose, if it is less than 1500, then 20 months is the time when you plan to add second agent. So this is what happens even with the metformin therapy. So this is insulin initiation is generally delayed. This is SOLVE study which has shown that it is delayed quite a lot. Not going to detail into that, although I said 7.7 years is the mean time, right? So documented delays in therapy intensification for people not meeting glycemic targets. This is patient on one OAD going into adding second OAD. It is 1.6 to 2.9 years. This is inertia. From second, you want to add third agent, and it takes about 6.9 to 7.2 years. And it took 6 to 7.1 years. Patient is in the hyperglycemic state to add insulin to that, and 3.7 years adding GLP-1 or premixed and bolus insulin. This is adding insulin is a basal insulin. So see how much time is lost and how much time the patient is in the hyperglycemic state, and this hyperglycemia contributes to the complication of diabetes. So there's a legacy effect. We all know legacy effect, uh, and a legacy effect is if you control diabetes in the earliest phase intention with aggressively, then you get metabolic benefits or even cardiovascular benefits later on, even when the HbA1c is not the same as in the intervention at the very start. Early glycemic control lead to lower HbA1c. We know that early intensification of treatment is associated with shorter time to achieve glycemic control, and early glycemic control lead to better maintenance of control for longer period of time, and early glycemic control lead to better long-term health outcomes and lower risk of micro and microvascular complication. This is we have got from extension UKPDS study, and even in the type 1 diabetes DCC study, which has shown that those patients who have a good glycemic control early in the course of diabetes, they have a better outcome even after 10 years of the stopping of the trial, although their HbA1c was same as the other group, which was a conventional group. So legacy effect is there in clinical trials, we know, but it also exists outside of the clinical trial population. This is a cohort study of managed care patient with type 2 diabetes and 10 years of survival followed for 13 years. And diabetes control during the first year after diagnosis was strongly associated with future risk for diabetes complication and mortality. This is a failure to achieve HbA1c less than 6.5 in first year. The hazard ratio of experienced micro and macrovascular complication was 1.2. Failure to achieve HbA1c less than 7 in first year, there is a hazard ratio. All-cause mortality is increased. So all-cause mortality is affected by the control in the early years of diabetes. Then taking action to intensify therapy can also reduce diabetes-related cost. This is a retrospective claim analysis. This is just to say that high conformance, intermediate, and low conformance, high physician took action to intensify therapy. In intermediate, mixed action taken time 50% of the time, taken 50% of the time, and low conformance means no action taken. When you compare with the low versus high conformance, pharmacy costs were lower in low conformance state. It has to be because you have not changed any treatment. Diabetes outpatient related cost 60% higher in low conformance at 18 months, and intermediate and versus high conformance patient diabetes related outpatient costs were higher at 12 and 18 months. So high conformance, although you have intensified therapy, physician took the interest, the cost of the treatment ultimately is lower when you compare with low or intermediate conformance patient. So we have to initiate therapy depending on the patient, and we have to shrug the inertia, and if we can shrug the inertia, we can have the better outcomes for the patients. And this is what is there from the ADA, that overcoming therapeutic inertia. This was launched in 2018 in 3 phases. Action program was there. In phase 1, there was convening of the stakeholders. Stakeholder mean various associations, various nursing and diabetes educator, those who are related to the diabetes treatment. And then phase 2 was charting a consensus, and phase 3 was implementing whatever we have discussed in the second plan. And from 2018 to 2020, ADA has initiated overcoming therapeutic inertia workshop and conferences on that. And they have reorganized three broad action components. And one component was research, that's identifying best practices. And another component is education and awareness, promoting clinician success. And third, of course, is collaborative barrier busting. This is a develop consensus, encourage innovative electronic health records tools, and improve peer practices and support ADA policy initiatives. So all these things are there now, and probably we will be getting a white paper on this also this year only, or maybe early next year. So these are the initiative priorities for the ADA. And overcoming therapeutic inertia, there are strategic drivers. One is a timely therapy optimization. Another one is improved care plan adherence. So this is a clinician job, timely therapy optimization. And this one is improved care plan is from the patient point of view. Both are critical, but neither is sufficient. So we have to, do the things in a such a way that we balance these things, and we stop that inertia, and make the patient HbA1c less than 7%. So this is what I've talked is a therapeutic inertia. Now coming to the personalized diabetes care, how we can translate all these things so that there is no inertia. Let's see that this is a case 45-year-old successful businesswoman who was diagnosed with diabetes 3 months ago during her annual physical examination. HbA1c is 8.5. Case 2 is 70 years old man with alcohol use disorder who has been diagnosed with diabetes for 30 years. HbA1c is 8.5. So the first thing we do is to make a target. What we should do with the HbA1c in both the patients. You will all agree with me that HbA1c target will not be the same in both the patients. In 70-year-old man who is alcohol use disorder and diagnosed with diabetes 30 years, he has many complications also. So for him, target 7% will be too high and he will land into complications. But in 45 years, he is required to prevent the complications, target of 7%. So set individualized target number one. That's the number one. This is the many of us have seen this colorful diagram many a times. So it is right from the disease duration, life expectancy, important comorbidities, and established vascular complication, patient attitude, resources, and risk potentially associated with the hypoglycemia or the drug adverse effect. So potentially modifiable is this one: patient attitude and treatment efforts, and resource and support system. So HbA1c should be done every 3 to 6 monthly. Target for most patients 7%, and individualized target based on multiple factors, including but not limited to whatever we have talked here, right? I will put it 7 factors are there. So from that you can drive. So going back to the previously discussed 2 patient who is 80 years with multiple long duration of diabetes, life expectancy is low. So here we should go less stringent. Maybe 7.5 or 8 is good enough for this gentleman, but for the lady, probably we have to be more stringent. So this is a decision cycle for patient-centered glycemic management in type 2 diabetes. Goals of care is to prevent complication and optimize quality of life, and agree on management plan that say specified SMART goals. SMART means specific, measurable, achievable, realistic, and time limited. So we have to do all these things, SMART moves. So deciding on HbA1c target in case 1, hypoglycemia risk is low, disease duration is recent, and there are no important comorbidities. There is no vascular complication, and patient preference tight glycemic control. Resources and support system is plenty. She is a businesswoman. So for her, target less than 7% is good one. But in case 2, we have hypoglycemia risk is high. His alcohol disorder, use disorder is there. Disease duration, life expectancy. These are all opposite of this one. So 8% target will be good for this gentleman, elderly man, without hypoglycemia. So shared decision making and collaborative care plan development is a must in diabetes care. Any plan formulated without patient's involvement is said to be a failure. So we have to involve the patient. He has to check the blood sugar regularly, and he has to, escalate or de-escalate the therapy in consultation with the educator or his clinician. So, what is personalization factors to consider here? There are various personalization factors like health beliefs, literacy, food and housing security, and all those things are there. And clinical characteristics like risk of hypoglycemia, vascular complication, comorbidities, glycemic control history. These factors are almost the same which we have discussed in the diagram. So, what are the components of diabetes care and management plan? We have managing blood glucose, protect heart health, kidney health, medication understanding, and addressing the key complication in diabetes. So blood glucose monitoring is the foundation of optimizing care. These are the ADA guidelines which I have projected, right? This is the chart one can make, right? And we know that early and appropriate intervention may improve patient chances of reaching HbA1c goal. This is the same which we discussed, that we are going very late in intensifying the therapy, but it should be not treat to failure. It should be treat to target approach. We have to target so that keep the HbA1c around 7, right? This is, we have to, be quick. So these are the guidelines, which are the latest guidelines. If you see here clearly here, the drugs have been specified over here. You don't have any, you can use this one, nothing of that sort. If financial is not an issue, cost is not an issue, you can use specific drugs, drugs in each of the settings. So lipids, you have to do the ACV risk assessment, then lifestyle modification, and then you have to assess and start the moderate or high intensity statin therapy in the patients. So kidney health, get ACR, and accordingly you give the treatment. And in addition to blood pressure and lipid control, another aspect is quit smoking, low dose aspirin if patient is over age 50 and have risk factors. Other cardioprotective medication like SGLT2 or glucagon like peptide, they have demonstrated cardiovascular disease benefits, so may be preferred. ACE inhibitors, ARB for proteinuria, and patient with prior myocardial infarction, beta blocker should be continued for at least 2 years after the event. And then another thing is minimize other complications like eye, feet, dental, and discuss at every visit regarding the obesity and weight management. We have psychological barriers because of the patient having diabetes distress or depression also. Not going to detail into that, but these are important things, and they may interfere with the goals of the therapy. Even OSA, which is always patient have snoring in the night, so fasting blood sugar is high. So again, weight is an important component. So if weight reduction is there, then you can improve the OSA symptoms also. So diabetes care plan is a roadmap. You go with the current status. You have goals and target to achieve. Various barriers are there like lifestyle modification, monitoring, diabetes education, social, emotional cost challenges are there, which have to be overcome to reach to the goals. And one question we should have always, have we done everything in our control to optimize therapy and support adherence at every visit and between the visits? That should be the question to all of us, whether we are benefiting the patient, whether our therapy is producing the desired results, whether we have achieved the goals or not. So this should be the priority for our diabetes care plan. So in the 2 cases which we have discussed, so case 1, personal, he doesn't have time to frequent inpatient visit due to busy schedule, and if he has access to technology, she can transfer the blood glucose reading to the clinic, and remote video visits can be arranged in that. And case 2, limited sources are there. So in this case, you have to do all the things for yourself. Low literacy is there, limited access to transportation, those things are there. Then probably one of our staff member has to call him, ask him what is happening, how is he, what is the chance whether he is having hypoglycemia, because hypoglycemia in this patient will be quite dangerous one. Coming on to the lastly to the pillars of the therapeutic inertia to break the therapeutic inertia. Number one is empowered patients, build engagement and trust. This is how you overcome the therapeutic inertia. Scheduled diabetes only visits where you discuss about the diabetes, HbA1c, not the other problems. Set and track, share targets and timeframes. Integrate screening for social, emotional, cultural and health literacy issues and provide support. Use thoughtful prescribing, consider cost, insurance, preferences, etc. Refer to diabetes self-management education and support system. Right? And pillar 2 is optimize care and treatment. Conduct practice-based screening for likely therapeutic inertia. Use personalized diabetes care plan. Use a team-based approach. Use glucose data and HbA1c to drive rapid cycle treatment intensification. Stratified follow-up based on the HbA1c and recent therapy. He will require generally a visit which may not be 3 months. Even you can call him 1.5 months and see to it whether the drug is effective or not. Then pillar 3 is leverage tools and tech to break the therapeutic inertia. Adopt a diabetes treatment algorithm and have it available at a point of care system. Create and use a patient registry. Integrate decision support into workflow. Adopt technology to increase number and quality of touch points like telehealth, texting, patient portals, and disseminate unblinded quality metrics. Learn from other success, right? This is to improve the decision making. So these are 7 easy strategies to overcome inertia. That's identify and engage patient with likely having therapeutic inertia. Start scheduling diabetes only visits. Arrange more frequent office visits. Check patients for barriers. Refer all patients for diabetes self-management education. Develop a care and treatment plan with each patient. Aim to adjust therapy anytime a patient HbA1c is more or BP is more or lipids are not at goal. Right? The key concept overview is a high quality and personalized diabetes care plan is an essential tool in overcoming therapeutic inertia. Not every body is the same. Personalization of the target and treatment plan is important to treat diabetes safely and effectively. The patient is the most important member of diabetes care team. Shared decision making with patient-centered approach is the way to achieve goal. To be successful, a care plan must be both optimize therapy in a timely fashion and address care plan plus adherence barriers, and at the same time, it should take care of the cost of the therapy to the patient. The bottom lines with the addressing therapeutic is there is a lot you can control in diabetes care and a lot you can't. So focus on what is in your sphere of control or influence. Do something to optimize therapy at every visit when a patient is above goal. Ask every patient about challenges they may be having with managing their diabetes at every visit, and make sure that therapeutic inertia can never trace us back to you. And do your jobs. You have to document it and leave it to the patient. Tell him by educating him that this is important. And the last line is very important. Make sure that therapeutic inertia can never trace us back to you. Right? This is a latest publication which has come into Canadian Journal of Diabetes. That is strategies to overcome therapeutic inertia and type 2 diabetes, a scoping review. Various things were, taken care, although there's many studies were taken into this. Therapeutic inertia and the management type 2 diabetes is common with causes at the patient, healthcare professional, healthcare system levels. Majority of recent strategies to address therapeutic inertia usually consisted of multiple interventions, but rarely targeted more than one level, right? Most strategies used educational intervention among patient or healthcare professionals, but gaps were found in addressing determinants of behavior change, how you can do behavior change with the patient. So we have to be united in overcoming therapeutic inertia. Number one is understand therapeutic inertia and notice therapeutic inertia in people with diabetes. Inform patient with diabetes about long-term diabetes management. Create personalized treatment and care plans. engage a multidisciplinary team and community support, and detect barriers to the self-management and refer. And all strategies aim to drive either timely therapy optimization or improved care plan adherence on the part of patient. So with that, every patient is different. I have discussed only two scenarios in which one 70 years or another 45-year businessman. That's very, straightforward. But in clinical practice, we see so many patients with different problems. So we have to change the therapy, personalize the therapy accordingly. With that, I close my talk. Thank you for the patience hearing. Thank you so much.